topic given to me is the medico-legal challenges in gynecologic oncology. I think I'm starting with that of the gynecologic oncology with you all today. And why gynae oncology? Because gynae oncology itself presents a lot of challenges. Right from the diagnosis to the management and also the palliative care. In the management, unless we have the confirmed diagnosis, we really cannot extend the best treatment guideline to the patient. And also, we have to select based on the diagnosis, based on the nature of the malignancy, how aggressive the tumor is, how indolent the tumor is, what should be the primary treatment, should it be the surgery, should it be the radiation therapy, or targeted therapy, or chemotherapy. Should the surgery be a part of the adjuvant treatment, or how we can offer the best in terms of when the treatment fails in the recurrent setting, what should be done? So gynae oncology is not only doing one surgery at one time and we forget about it. These are all issues which are important to understand the best care which we can really deliver to our patients. We understand once the diagnosis of gynae cancer is made, of course, we have to address the issue of the survival. Not only survival, but also, of course, the quality of life. And that is how it is really challenging. Surgeries, as we all understand, are very, very extensive gynae cancers. This requires the quite extensive surgery of the retroperitoneal node dissection, also the surgical cytoreductions, bowel resection, anastomosis. Not only we are concerned about the morbidity intraoperatively, but also the long-term effect of these surgeries giving to the patient to that of the quality of life. Maybe for an example, if I say the simple lymphedema, is it really required? So optimization of the surgical management based on the gynecological cancers is very, very important to really focus on. That is how the focus over the period of time in oncology is changing to that of extending the quality of life of these. These are the gynecological cancers. And we are aware that many of these gynecological cancers are diagnosed in early, you can say, age, when the patient is young. Thus, the fertility preservation issue is also very, very important for these patients. Extending the quality of life to these patients, so far as surgical management is concerned, I think we are changing and transforming our surgical practices to the recent advancement of extending the quality of life by choosing the minimal access surgery of the laparoscopy as well as the robot-assisted surgery. Ultimately, we are extending our treatment to these patients with the goal of extending them the best survival. What we are doing today doesn't speak of gynae oncology practice at all. What speaks is what happens in 5 years when we have done surgical management for these patients. So we have to consider all these aspects in gynae oncology while managing the patients of gynecological cancers. And that is how the gynae oncology is at high risk of the medical challenges. Simple delayed diagnosis. There are diagnostic dilemmas. Various reportings from one or the other centers. This is what actually brings us all the more concern in the care. And we understand that these are high morbidity procedures, there are a lot of surgical complications, and also how to prevent the surgical complications is also very, very important. And for that matter, actually, who is trained in what? That matters a lot. And that's how we can extend whatever is the best possible actually weigh the gynecological oncology, which is at high risk for all these. And in current scenario, look at the increasing patient awareness and the digital access to the medical information. I think we are all aware of it. Our patients are more intelligent now. They will ask you a number of questions based on whatever is there. And of course, the AI, whatever we write today that will be posted to the AI will tell whatever the opinion given, whether it is right, what should happen. So I think these are all challenges which we are facing today. This is what is the current scenario. We are concerned about the high emotional, financial, as well as the reproductive stake in gynecological cancer especially. So there is a need for the shared decision making. We have to include the multidisciplinary team for the medical, and this requires a meticulous documentation. So I think the need has already been, I think, emphasized by Madam Shada Jain, as well as, I think, Dr. Jitendra. And also, it is the good documentation which is the best legal defense. I think we all understand, but we require to bring it to our practice in day-to-day life. What is medical negligence? Of course, we all understand. It's whenever it is asked about, it is important for us to understand what is medical negligence. It is the standard of care which is expected from the competent practitioner. Every patient is expecting. And other than this, there have been lacunae. What is the duty? What is the duty of care? Any breach in the duty of care. And of course, leading to the causation as well as the damages in terms of the legal liability. So common medico-legal challenges in our day-to-day practice in gynae-oncology, of course, other than the delayed diagnosis, inadequate informed consent. Patient thinks that, I have been betrayed. And surgical complications. Let the patient know whatever is the documented surgical complications globally. So we are now focusing on to the global consent. That yes, there is about 2 to 3% chance of the ureteric injury if suppose we are going for the radical hysterectomy. Should be told to the patient what are the chances of these actually the complications. Also, when we are dealing with the fertility sparing surgery, of course, we have to look into the legal concern of the future infertility disputes. So I think we have to be wiser in assessing this. I shall be coming to this point again. Also, chemotherapy-related toxicities, of course, one has to understand sometimes this is actually, there is failure to counsel about simple chemotherapy induced. Keep taking chemotherapies, but yes, we require to counsel them about this. The documentation gaps, and also I think it's the biggest problem that can lead to the weak legal defense. I think we understand this, but what is important is to modify. So delayed diagnosis, I just give an example of this common scenario. Like persistent menopausal bleeding, ignored. Suspicious pap smear or any kind of the biopsy without follow-up. Patient doesn't even know about it or not has been communicated. Suspicious adnexal mass which has been misdiagnosed. It is malignant, but it was diagnosed as maybe benign. And delayed biopsy of any suspicious lesion. So I think we require to incorporate in our practice the most important thing. Let the thing be benign, fine, document it. If it is benign, you are, I think, very clear about it. But if any lesion is suspicious and we don't biopsy this lesion, and later on this is biopsied and proved, of course, we are giving, unnecessarily the problem rather related with that of the medical legal issue. So we can prevent all these things by following the guidelines. In oncology, we have to follow the guidelines. I cannot individualize the treatment myself or anybody else. We have to respect the guidelines, what we have to do, based on the evidence, whether it is level 1 evidence, level 2 evidence, or level 3 evidence. That's how the documentation required to be done. Also, it is important for us to understand that we have to give the timely referral. So timely referral and document the patient non-compliance. If you have advised the patient that you have been diagnosed of malignancy, you have to go for the surgery or maybe the radiation therapy or chemotherapy. Patient doesn't come. Please document it, the non-compliance regarding whatever the advice which you have given. Look at this NCCN guidelines. It has made very clear that who should do what. So not only in gynae-oncology, we must understand that the gynae-oncology as a specialty has been made responsible for taking up the management of the patients like ovarian cancer, uterine cancer, or for that matter, any gynecological cancers. So all these things have been incorporated into the guidelines. And any of the even suspicious ovarian mass has also been asked for that these should be referred to the GYN oncologist. So we should be aware of the available guidelines whenever we are really handling such patients. And it's important for us to understand that any kind of the lack of the communication, which has been emphasized even earlier as well. I just set this example, the UK Coroner's Inquest 2024. This was very important issue. It was a 44-year-old woman with the persistent abnormal gynecological symptoms. There had been diagnostic dilemma in the sense that multiple missed opportunities for the investigations and referral, and ultimately this woman was diagnosed in advanced stage of endometrial cancer. Now this coroner identified the missed opportunities for the earlier intervention and concluded that the diagnosis had been delayed due to the multiple system failures. And this was then issued a regulation 28 where the prevention of the future deaths, that was actually the looking at. Now, medico-legal learning in this particular case was, because this was into the newspaper globally, that's how the early diagnosis of the endometrial cancer could have saved her life. We understand that the chances of cure are high. And that is how it is important for us to understand that there has to be a closed loop communication of the investigations. If we send the patient for ultrasound, I think we must get the communication from the radiologist. Also, actually, to that of any of the other, maybe the colleague of the other specialty, we should make a closed loop. And that means we are aware what's happening to the particular patients. We just write reference to this, we don't know what's happening. What actually abnormality has been detected and how we have to really take into consideration. So this was the learning out of this case, and also the timely referral pathways. If it has not been diagnosed, we are thinking that no, there is some kind of suspicion, kindly refer it in time so that we do not ignore about it. Documentation of any abnormal finding must be there. And also, this is the very biggest challenge what I feel in our own practice, follow-up system for the missed appointments. Somebody is asking you for appointment again and again, that she is having some problem because of one or because of the other, because of our busy schedule, because of our limitations to the support staff, somehow that patient is missed. And then later on, this patient suffers, and that's how the medico-legal issues come. So that's how I think these are very, very important issues. Informed consent is the cornerstone. Informed consent in gynae-oncology, I think Madam has already pointed out that we have the FOXY, you can say the consent forms available based on whatever the procedure which we are doing. But it's important for us to go for the informed consent document, which has to be signed by both, by us as well as. So we have to take out time. This requires a lot of time at the time when we are taking the consent. So actually, this is what is important, right from the diagnosis to the planned procedure. This is what is planned, but these are the procedures may be done on table based on whatever the diagnosis we have. For an example, if it is the complex ovarian mass, we have to explain that on table when we are taking this patient, excision of this ovarian mass, frozen evaluation, that is going to give us the diagnosis, and based on the frozen report, if it is going to be malignant, we are going to stage this patient with the retroperitoneal lymphadenectomy, omentectomy, peritoneal biopsies. That's how I think we have to take up all these issues. We have to understand, rather let the patient know of the risks and the complications. Possibility of conversion if we are going for the minimally invasive surgery to that of the open surgery must always be told right in the beginning. Possibility of conversion if we are going for the minimally invasive surgery to that of the open surgery must always be told right in the beginning. And also the fertility implications wherever indicated, any possibility of the stoma, whether colostomy, ileostomy, or otherwise. ICU admissions is very, very important. And the last point is the death. Death actually in all the cases has to be documented. If we are looking into the consent forms of the West, they always mention about it. But here, there had been a lot of dilemma. We are also concerned, and being in the GYN oncology field, if I may share with you, it becomes very tough to say the patient who is fighting out with that of their own life is standing, or rather in front of you, to say that yes, there is a chance of the death. But what I feel that based on the in the consent, if it is high risk, always mention it. Take the high-risk consent and then take the patient up. But because otherwise, nobody can save us. And so special focus, especially in fertility surgery, recurrence risk must be told about. And also the completion surgery later and the need for the long-term surveillance. And selection of the patients is very, very important, when to do, when not to do. Here comes a patient of 27 years of age who had been nulliparous, and rather who was diagnosed of stage 1A ovarian carcinoma, had undergone fertility sparing surgery, but she had recurrence after 3 years. Now then comes the medico-legal questions, and the key questions are, was the risk discussed? Were the alternatives explained? Was completion surgery discussed? Was fertility counseling documented? So these are all questions which we have to answer. So it is important for us to document the checklist. So consent, documented conversation, not a signed form. So this is what is important. It is not just a signed form. It has to be a consent which is documented conversation. This is what is important. Of course, we have to include the team members, that who all are going to manage the patient, who all are going to follow up the patients. And that's how the team work. The surgical complications and litigations, I think we are all concerned about. This is what is the list. That's how it comes. And that's how we have to manage. Simple ureteric injury, I think we are facing a lot of problems of the ureteric injury naturally, because we are working towards nearby ureters all the time. And this we should minimize. What I feel, and I just want to share my personal view, when I was a postgraduate, I didn't know how to dissect the ureter well. It was actually your learning which can make you expert. So first of all, everyone should be actually able to manage all these structures very nicely during surgery. Be confident about it, and also know that yes, there is always a chance of the ureteric injury. Even if it is 2%, if we miss it, what happens? the complication actually leads to that of the bad quality of life, and how the patient can be that furious to go for the medico-legal action. And that's how these are required to be managed. And documentation is, of course, is your best friend. And that's how, what is important is all the notes are very, very important. I think we are into the digital era where we have the system in front of us. We are so tired, like in gynae-oncology, if I say, we are so tired of the surgery itself. 4 hours, 5 hours, sometimes 10 hours. When we are taking cytoreduction at 10 hours, 9, 10 hours are, I think, usual for us. Going for HIPAC, another 3 hours. So I think we should not forget, actually, to note it down, everything, right from the OPD notes to that of the multidisciplinary tumor board. In oncology today, we are practicing, ma'am, and for all, every patient goes through the multidisciplinary tumor board, even if it is early stage gynecological cancer or it is advanced stage gynecological cancer. This documentation is very, very important, so that the consensus is for the better, offering the best quality of life to the patient. And that's how the counseling details, consent forms, operating findings in detail, and post-operative communication. Post-operative, when we are seeing the very next day, we have to counsel the patient attendants and also the patient herself, that how she is progressing, whether her progress is satisfactory. And that's how that is discharge summary, I think, should be very much detailed. And the need for the adjuvant treatment must be documented, that this patient doesn't require any adjuvant treatment. This patient requires, another patient requires radiation therapy or chemotherapy. If this patient goes without any advice for the adjuvant therapy, and she requires, in fact, the adjuvant therapy, then basically legally we are liable. That's how it's important. And malpractices litigation, multidisciplinary cancer care is very, very important. And what is important is dissenting views. Consent we know about. What is dissenting view? So please do not ignore that, and that should be really rather concerned about. We are concerned, we must document, record the dissent. This is what is very, very important. What are the expectations, and also the confidentiality and the disclosure about the patient diagnosis is also very, very important. So communication failure, the studies show the communication breakdown contributes significantly to that of the malpractice claims. Unrealistic expectations, poor disclosure of complications, lack of the family counsel, and even WhatsApp advice without documentation. I'm just finishing. That's how it's important. So AI, a digital era, we understand, and that's how we will have to look into the consent may constitute the data protection breach. Data protection breach is important. So that's how we can risk reduce these strategies, and that's how we conclude that the complications are not always negligence. Informed consent is a process, not merely a signature. Documentation is the strongest legal safeguard. Communication prevents many disputes, and multidisciplinary guideline-based care minimizes the medico-legal action. So this is what is our team of the gynae oncologist, and I thank you all.